we're going to start on some legislative activity. Then we're going to move to some regulatory and judicial that are kind of smushed together purposefully because those two things have become so intertwined. You all may have seen in the papers that there has been a lot potentially going on in Congress this month, and it turns out actually not that much is really going to happen, but we thought maybe a lot would happen. So to step back, routinely, Congress has to fund various federal agencies. And so that gives us a legislative vehicle that we sometimes try to kind of get items on that moving train, see if we can get some new laws made to address policy issues. And so this Friday, March 8th, and March 22nd are two important days when different important parts of the government are going to be funded and Congress has to act. And so that's why you might have heard some discussion about, will there be a government shutdown? And if there's not a government shutdown, that means that a law has passed to fund those agencies. And sometimes other things are added in that vehicle. There had been some discussion that maybe those vehicles could include some pretty substantial health policy initiatives, and we'll go over some of them today, but I wanted to give you the context now because long story short, it does not look like anything substantial is going to be included in either of those packages. So what we're going to talk today about substantively is something that was going to come back up in what's called the lame duck session of Congress. So that's between November and the election and the beginning of the next Congress in mid-January. That's the next time we're probably going to talk about maybe real changes happening in the health policy arena. You never know what could happen, but at this point, I don't think anything is going to happen in the next few weeks that would kind of change how we all see the world and what we're obligated to do, or any even in some cases, good policies are not going to get passed that maybe some of us were advocating for. So the top issues that I think have been percolating have been really focused on healthcare costs. And that includes competition, consolidation, price transparency. These are issues that come up in Congress with staff, no matter the side of the aisle. So Democrats and Republicans are talking about healthcare costs. If you see any polling, any election polling, political polling, which is really kicking up this time of year, that's always a top issue for voters. And so it's a top issue for lawmakers. It's been interesting that there have been so many different policy ideas. It's kind of hard to summarize each one individually, which I won't attempt to do today, but I wanted to give you guys a sense of the categories of what's going on. So on the increasing transparency front, there is this one package that did pass in the House of Representatives late last year called the Lower Costs, More Transparency Act. That might be one to file away in your brain because at least the full House of Representatives was able to come to agreement on that piece of legislation. It didn't really go anywhere in the Senate. But that covered a few of the conceptual categories that I think are important to keep in mind for tracking purposes. One has to do with Medicare rates, and stay with me because this is relevant for employer plan sponsors. Sometimes it's referred to as site-neutral payment reform. Basically, this is the idea that Medicare pays more to some types for services at certain locations than at other locations. So Medicare will pay more at a hospital outpatient department than they would at a standalone physician's office, even if I'm going, same person getting the same item or service. It could be substantially more lucrative at the hospital-based department. And so the concern is that that has led to consolidation where hospitals, because they can make more money by buying up these standalone practices and increasing the rates for reimbursement, have led to less and less competition in the provider market and more hospital consolidation. So that's why I mentioned that this might sound like a technical issue of, reimbursement rates in Medicare. You might say, why does that matter to me? But it matters because I think of the larger incentives that it's setting up in the market. Also, as we all know, a lot of employers tie their rates to Medicare reimbursement in some cases. And so we do watch Medicare reimbursement rates. And we also just general health policy rise, right? Want to understand why would a service at a location this year cost 3 times as much as last year when I'm going to the same doctor in the same building and I have the same condition. That also catches employees by surprise. And so we do hear feedback from some employers saying, I don't know what happened. They had this sign up and it costs more. What's going on? So there have been some efforts to undo that and basically have Medicare payment parity, where Medicare pays the same amount for the same items and services at the same, at whatever location you might go to, whatever the site of care is. There has been some success in that, but the idea is that it needs to be broadened. And so there have been some efforts to expand what's called site neutral payment reform. So that's one category of items that's included in a lot of the bills that are kind of active and out there, including the Lower Costs, More Transparency Act. Transparency, as you can tell, I imagine you could infer from the title of this legislation, is also a major policy priority right now. I know you guys have a breakout later today that's going to focus on transparency. It's been a focus in the regulatory arena. It's been a focus in the legislative arena. And what some of the more recent legislative ideas would do would be to codify it. And that means in some cases, federal agencies have come up with transparency requirements for group health plans, in some cases for hospitals. And they have, hundreds and hundreds of pages telling us all what these transparency requirements are intended to do. They're all supposed to help everybody understand costs better, to lower costs ultimately. But the fear is that depending on when the administration changes, perhaps in the future, some of those requirements could be walked back if they're just in a regulation or an FAQ or something like that. So the idea is, let's get those into law so that we all have some certainty on what the requirements are for transparency and some consistency over time. So there are several potential laws that would also codify or put into law some of the transparency requirements right now that just live in regulations. They also would expand who has to do transparency reporting. So now it's really primarily hospitals and payers, but it could expand to things like imaging centers and other things like that. So transparency is a big bucket. I know for this audience also, I couldn't neglect to mention some of the PBM angle on all of this, because there's also a big push on PBM transparency. In this case, it's more PBM to plan sponsor, where some of the other items I just mentioned are the entity with public disclosure. This would be kind of semi-annual in some cases, annual in some cases, information that the PBM would need to provide to the employer plan sponsor about rebates, costs for drugs, a whole laundry list of information that plan sponsors have indicated they would find helpful to hear from their PBMs to be able to make good decisions and be good fiduciaries, as we'll talk about a little bit more later today. That's kind of the main items that are in the Lower Costs, More Transparency Act, and that's what has been successful in the House of Representatives. I did want to mention, I'm not going to go through all of these, but there are other legislative efforts in the Senate which are similar, but in some cases different than some of those items I just mentioned. And on the PBM front, I wanted to mention some of them go farther than just PBM transparency. Some of them would prohibit spread pricing. Some of them would mandate pass-through of rebates to plans. And so there's a whole kind of a range of what might happen in the PBM space in different legislative vehicles. And I wanted you to know it really is pretty hard to track. And so I wanted to just give you the high level there. But these are all policies that I mentioned that failed to get included in any of the vehicles that are traveling over the next 2 weeks. My sense was that the Lower Costs, More Transparency Act, the item focused on transparency, had the best likelihood of potentially being included in some kind of vehicle, and that wasn't achieved. My understanding is that there are different views, even among Republicans who've been supportive of some of these efforts, about the extent to which they should be legislating with regard to private relationships and private contracts. So still a lot of differing views, I think, on all of this within Congress, but everyone seems on board on a high level that they should be thinking about good policies to try to lower healthcare costs, and there's a substantial amount of focus on PBMs as part of those efforts. So that's something to keep watching. Changing gears a little bit, I mentioned that these packages that are going to pass in the next few days, they're what we call skinny packages. They're just going to fund the government and maybe do a couple other cats and dogs. A lot of the things in those vehicles are only being extended till the end of this year. So that means that by the end of this year, Congress is going to have to figure out again how to fund those agencies and how to extend those items again. For example, things like community health centers they funded, but they only funded to the end of this year. So that means at the end of this year, we have to go through this exercise again. The thought is that maybe some of those items I just mentioned are going to come up again, bigger picture issues. Something a little more narrow that is this gets a fair amount of attention is a response to the pandemic that we've understand employers found helpful, which was the ability to offer telehealth, pre-deductible, and a high deductible health plan. So that could be first dollar coverage or just with a lower deductible than normal. And this was allowed by law during the pandemic, and it's been extended a few times over the years. As you all know, typically a high deductible health plan can't cover items and services before the deductible is met unless it's a preventive care or there's a few other exceptions. So this was added to the list of exceptions. We heard it was really helpful during the pandemic, in particular for employers who are full replacement where they just have a high deductible health plan. So the issue has been that this flexibility has been extended, and again, it's not a requirement, it's just optional for an employer. They could choose to do this if they offer a high deductible health plan. It's been extended a few times since the end of the public health emergency, but always kind of in a cluster of a way is a nice way to say it. They're always like a weird gap in between with the extension, or it doesn't work for non-calendar year plans. It's kind of been a bit of an issue in how it's been extended each time. And we've heard from many plan sponsors that that's not how you all operate, right? You don't want to hear on December 27th that you have a new flexibility you could use January 1st, right? You made that decision 2 years ago. And so kind of the stop and start nature of this special flexibility has not been that helpful because of the way that it's been rolled out in such a clunky fashion. So the efforts for end of year this year are to make this relief permanent so that on a permanent basis, employers who offer high deductible health plans can choose, if they want to offer telehealth pre-deductible or in some cases for no cost share. We've heard things like that's been really helpful for mental health benefits. But I was really interested in yesterday's presentation to hear that it sounds like a lot of folks want to go back in person for their mental health care. But in any event, there's still a fair amount of momentum on the telehealth side. So that's something that also might be on the menu of items for year end this year. More generally, I just wanted to make an observation on high deductible health plans and HSAs to the extent some of you guys offer them. I didn't want to indicate that this is the only policy idea that's out there. It's really administration contingent. So I've worked in Democratic administrations and Republican administrations. I worked on some administrations where like you just don't really talk about HSAs or high deductible health plans unless absolutely necessary. And then I've worked for other administrations where it's the top 20 policy items, 15 of them have to do with high deductible health plans. So that is all to say, like, keep this in your mind, because if we get a change in administration, we may be talking a lot more about account-based plans. And there are a lot of ideas about how to expand HDHPs other than just telehealth, right? I could list you 30. So just wanted to kind of park that account-based plans are something where I find that we think about a lot, and then you kind of put aside for a few years, then you think about a lot. And so we might be coming up to a time where we have to kind of re-engage in good policy ideas with regard to high deductible health plans. And something I hear about, for example, a lot is getting more flexibility to be able to allow more access to primary care, for example. So HDHPs and HSAs are still, I think, an important issue for employers to think about, but not so active on the policy front this year except for telehealth. And I know you're all excited because it is ERISA's 50th anniversary. So, congratulations, everybody. Yes. We will actually, if you can believe it, there will be parties and other things like that to celebrate. So going to be a fun time. But on the advocacy side of things, it also presents a great opportunity to try to reaffirm and confirm the importance of ERISA preemption. As was alluded to yesterday, many of us who work in this area day to day have been worried about all the recent developments that are eroding ERISA preemption. So we've seen activity in the states we talked about yesterday with regard to pharmacy benefits in a lot of cases, some things that don't relate to pharmacy benefits, some court cases that seem to misunderstand the scope of ERISA preemption. The federal department that has jurisdiction over ERISA, the Department of Labor, filed a brief earlier this year in an important lawsuit in Oklahoma where they described their view of ERISA preemption, and it's much narrower than what I think many of us thought the scope of ERISA preemption was. And I'm troubled that sometimes discussions with congressional staff when we're talking about laws, this issue has come up where sometimes they'll, pontificate, should we exempt this from ERISA preemption, and maybe say that employers have to do this in addition to whatever the states tell them. So I think 10 years ago, 15 years ago, ERISA preemption was fairly sacrosanct. I didn't think I had to talk about it too much. We didn't have to defend it too much. But now it feels like there's a concerted effort to break it down a bit. I understand states want their policies to have the maximum impact, and there are a lot of people, right, covered by self-insured employer plans. So I understand the motivation, but we're worried. And so the ERISA 50th anniversary is giving us a good opportunity to try to go to Congress, agencies, the general public, and try to explain why ERISA preemption is important. I'm not a marketing person. That's not the easiest thing to like make sound cool, but we are trying to, say that in the different words that I'm saying to you right now. We're trying to come up with better words that make a normal person understand, what we're talking about. But it's a bit of a challenge. But I did want to mention on the legislative side, there are several legislators who are on board, who are really worried about the erosion of ERISA preemption, who have been really good allies as we try to fend off some exceptions to ERISA preemption as we kind of deal with them daily. We've talked to them a lot over the last few weeks, for example, as we were all trying to figure out if there would be new substantial policy made in these next few legislative vehicles. And one of them, Virginia Fox, who is a representative from North Carolina, put out a request for information a few weeks ago, kind of noting the anniversary of ERISA ERISA, including ERISA preemption, and asking a bunch of questions about its value, and a range of other topics she included as well in this request for information, including on fiduciary status, who should be a fiduciary. She asked questions about specialty drugs, prohibited transactions, which is an ERISA word for the rules on like when different parties kind of need to be careful about how they interact to avoid violating ERISA, and a whole litany of things. So it's a pretty big request for information. So you guys know what a request for information is. It's usually the very beginning of a policy process. If you have an idea as a lawmaker or as a person in a regulatory agency, you might put out a request for information because it's kind of percolating and it's in the ether. You don't have specific ideas, or you're kind of worried that different stakeholders are going to have a lot of different views, and you want to know what all those are before you come out with like draft legislative language or a proposed regulation. So she's trying to figure out, where are the stakeholders on all of these issues, and is there some kind of law we could pass that would help and be good policy? So we're working on crafting a response here, and I just wanted to mention that it is a little nuanced, like everything in this space. We have some trepidation with just coming out and saying, expand ERISA preemption due to the fear that that would cause a backlash by the many entities out there who would like to narrow or do away with ERISA preemption. So I think we're going to go in the kind of in the vein of to confirm and clarify ERISA preemption. That is to say, we think it's currently very strong. We disagree with DOL's interpretation sometimes. We disagree with courts sometimes, but we think ERISA currently is very strong. We're worried about a negative inference from a lot of letters going out there saying ERISA must be strengthened, it's not strong now. That said, there might be some letters that come in that say ERISA is not strong, please make it stronger. And there might be some letters that say, please get rid of ERISA, it's awful. So, it's a little scary once a policy process begins. No one has control over where it goes. And the idea is everyone can say their opinion, it's valuable. So I don't know where this is headed, but I wanted you guys to know that it's not like, March 15th, request for information comments due March 20th, we get a new proposed law to look at. That's not the pace at which this is going to go. This is going to be a long time coming. But I wanted you to know that there are some champions in Congress. I think that's good news. And we're working on getting more champions in Congress. I think it's interesting that Congress is thinking about ways that they could solidify ERISA. And I think it's something for us to watch. And I wanted you to know that some of us working in this space are very careful about how we go about that to make sure we don't bring about any unintended consequences or overly politicize the issue. We like when everybody likes ERISA preemption, and we don't want it to become a partisan issue. So trying to thread all those needles, but that's going to be something interesting to see all the responses to that next week. So now I'm going to pivot to some regulatory and judicial updates. Some of them, as I mentioned, we touched on yesterday. I wanted to level set a little bit first about like what does it matter that it's the fourth year of administration? That's relevant in the regulatory sphere because we all understand, right? If you have a deadline, right, at work, you have to really prioritize, and sometimes you'll have bandwidth issues. So that's what's going on here at the federal agencies. Imagine you had 50 things you wanted to do over an administration. You've done 12 of them, and you're trying to figure out what in the world you're going to do, how you're going to wrap all this up in the next 9 months. In addition to that, they have what's called the Congressional Review Act deadline, which basically means the next Congress, were it to change hands, would be able to undo any final regulations adopted by the current by the current agencies. And so an administration usually likes to wrap up any important final rules well in advance of the next Congress because they don't want the next Congress to be able to overturn their rules. I mention that so you understand that this spring and summer are going to be really busy on the regulatory front, I would expect, less so in the fall and winter, because it's risky if you put out a final regulation, 3 days before there's a new Congress, that new Congress could come in and undo that regulation. So there is some date that I currently cannot calculate because it relates to the legislative days in the calendar for 2024, but some date in the fall or late summer at which point the regulation is considered safe. And so there's somebody in the White House right now who is telling everybody, like, get your work done. But someone told me, like, take your vitamins, drink water, like, we got to get everything done by this day. So they really push you pretty hard until the end there because you're trying to get everything done. So that means they're prioritizing, right? And so I mention that because sometimes we all have issues we care about and you wonder, why aren't they doing anything on this? It's because, like any of us, they have to prioritize in their job and they have limited resources like all of us. So what I've heard is their priorities are, reproductive health care, mental health. We'll get into that a little bit more. And then some of the rulemaking that they did under the Affordable Care Act on short-term limited duration insurance. I know these are probably not all top issues for you guys, but I wanted to mention it to you because it gives some context for maybe why they aren't going to have as much time to do some other things or why it feels like it's taking them so long to clarify the thing you care about. It's because they're trying to wrap up their priorities and they kind of move in order. I think in the State of the Union address from the president tomorrow night, that's always a good window into what they have cooking for their top priorities. If it's mentioned there, it's really important. Sometimes they put stuff out day of so the president can say, and just today we did whatever, so tomorrow, keep an eye out. The ACA anniversary coming out in the end of March, that's a time to keep an eye out. It's a little more political this year than it is in the normal course. So in like year 2 of a presidential administration, I'm not thinking so much about how the president's going to talk about that or maybe make something political or push the staff to get something out fast so he can talk about it on the campaign trail. But this year, that's a factor. So that's just something for all of us to keep in mind. I also wanted to mention that there's a lot of litigation that's happening after final regulations come out. And in my experience, earlier in my career, usually there would be a 2-step process that I was familiar with before we would all know what the new law meant. The law was passed by Congress, the agencies proposed a rule, the agencies finalized a rule, and then we all learned about it, right? Maybe we had to get FAQs or something to really make sure we got it, but then we proceeded and then we implemented it. Now it seems like more and more the third new phase is then it's litigated, and then we have to watch its litigation. For example, the No Surprises Act has over 25 lawsuits right now, each on different issues that we have to track in all these different courts. So it does make it a lot harder for plan sponsors to say, all right, time to really focus on implementation this year when you ask your advisors or your outside counsel or anybody and say, what does this mean? You have to say, oh, I don't know. That's being litigated in 7 circuits. So it adds a lot of uncertainty. I wanted to mention that there is a case in the Supreme Court now, actually 2 cases, that could actually exacerbate this issue because currently, in a lot of cases, courts will defer to a judgment call made by an agency in regulations. If a statute's not clear and an agency kind of uses the information that it has to make a good decision, someone challenges that in court, usually there is some kind of preference towards the agency's view. There's litigation now pushing back on that preference towards the agencies where this plaintiff wants judges to just look at the agencies and the plaintiff's view just equal and not give the agencies a preferential view. So if courts stop deferring to agency interpretations, I think that will lead to a lot more litigation on regulations because parties bringing the suit will assume that they have a better chance of being successful. And we all know it's really expensive to bring a lawsuit. And so that's just kind of like a better proposition if you said, it's a lot of money, but I think I'm going to win. So that case at the Supreme Court is not about employee benefits. It's about fisheries. I won't get into it. But I wanted you to know that that's out there too, because these are things you might be hearing from, say, your consultants or your outside counsel over the next 9 months. And I don't want you to be surprised if you said, why are they telling me about this fishing boat case and the deference standard? It sounds ridiculous. It's important, and it could mean that there are going to be a lot more lawsuits following final regulations. I think that means that Congress is going to have to be a lot more specific when they pass laws. The agencies are probably going to have a different approach to how they finalize regulations. And so it will kind of impact all of us and how we advocate, when we advocate, and how we implement and how we comply. So that's some backdrop. Lastly, I wanted to mention, based on that timeline I mentioned to you guys, which is essentially that final rules have to be done by this summer, I don't expect a lot of new proposed rules to be coming out this year that none of us have ever heard of. That would be very hard for them to propose something and finalize it by the summer. I mean, anything is possible, but that's almost not possible. So I would, if it gives you any comfort, the issues you're aware of, mental health parity and other things we're going to talk about, that's what you're going to be dealing with this year. It's not going to be the first year of an administration where it's like 12 new things you've never heard about in your life and now you need to analyze it. We're dealing with older stuff that's coming to conclusion, and we're tracking it to make sure it's implemented best as possible. So that's kind of where we're at in the regulatory life cycle currently. On the litigation front, I did want to talk a little bit about the case that we discussed yesterday briefly, just so you guys have some context. And I do think it's an interesting backdrop for basically everything we've talked about today. So as the panelists talked about yesterday, there was a lawsuit filed in early February by a plaintiff who was actually like a health policy employee for Johnson & Johnson. She sued the health plan. It is a class action, essentially asserting that the plan and its fiduciaries violated their fiduciary duties because of the way in which they essentially chose and monitored their PBM. Really brings up a lot of issues with spread pricing and with specialty generics and a lot of other issues. There's a lot in there, but the essential legal complaint and claim is relating to ERISA fiduciary duty and the duty of prudence and loyalty that plan sponsors have, fiduciaries have to their plans. So that I wanted to mention is currently what we have is the complaint. That was what was filed that yesterday was mentioned. Could be helpful for you guys to look at. I would not normally recommend that you read a 74-page legal document if you're not a lawyer, but I think this one is good to read for everybody. It's an easy read. You'll find it interesting because it takes on a lot, right? It kind of takes on the whole prescription drug supply chain, all the different actors in it, and brings up a lot of stuff for color that I don't think is necessarily legally relevant, but it's setting the stage. But I wanted to remind everybody that a complaint is just a set of allegations that's filed by a plaintiff. So like I could file a complaint today suing any one of you based on just 12 things I felt like typing up. Okay, it's just what they said. A good lawyer would hopefully have some truth to what they put in a complaint. But I did want to mention we have not yet heard whether the allegations are true or any defenses from Johnson & Johnson. The expected next step is that the defendants in this case will file what's called a motion to dismiss. So that's when the defendant says, even assuming everything you just said in this complaint is true, I don't think that you have stated a valid case, and I don't think you've met your burden of being able to sue me, basically. You haven't pled enough facts. You haven't put enough out there, and I don't think this is, even assuming this is all true, don't think that you've stated an actual breach of fiduciary duty here. So that'll be the first effort. After that, depending on what happens there, then we get into what's called discovery. And that's when the parties get information from each other on the facts. And I imagine in this case, the plaintiffs will ask all kinds of questions about the pharmacy benefit design and different service providers and all of that. I mention that so you guys, again, are not surprised because I expect several more cases similar to this to be filed sometime soonish, because what we have is the playbook from the 401k fee litigation, which is different but similar in some ways. What we typically will see is a plaintiff's law firm will hone in on an issue. And then they will file a lawsuit in a few different places, a few different judges. Sometimes they'll make their allegations a little bit different. They're fine tuning it, what works, what doesn't, what venues are favorable, what venues aren't. And then they try to get to this discovery phase I just mentioned, because that's usually when employers and plans are more likely to settle, because sharing all of your information with plaintiff's counsel is, not an enjoyable experience. So I think they're trying to figure out a new business in which they sue a lot of employers and they get a lot of settlements. In the 401k fee litigation, there were hundreds of lawsuits filed against employers in the first year or the first few months. I think it was like 6 or 7, but over the last 10 years, it's been hundreds. So that's why it's really important that we all focus on this. I don't want to scare you, but I also don't want you to be surprised if you see another one pop up. That's not shocking, right? We knew that. If you're a plaintiff's lawyer, that makes sense, right? You want to see what's effective, what's the best arguments to make, what's the best places to bring these lawsuits. So I think there are a lot of defenses that Johnson & Johnson has, and it'll be really interesting to read their filings in this case. There are different issues. I won't get into all of them today on whether plan assets are actually involved and where we really have ERISA fiduciary duties coming to bear. I think that's the case in the Johnson & Johnson case, because there's a VEBA, meaning a trust that funds the benefits. But for a lot of folks, they don't have a VEBA. So there might be defenses regarding the fact that there weren't actually losses to the plan or participants. And there are other arguments I expect to be made similar to what was discussed yesterday, where although some of the drugs are cherry picked and look like they have this huge markup compared to what you could get, from a cash price, I think that they will make arguments about the aggregate value of the drug benefits in the plan and what the plan pays in the aggregate. I don't know whether these will be successful in court. I just wanted you to know there are a lot of defenses that are going to be coming up here. And I think in some cases, factual corrections of the record. So just to reiterate, whatever was asserted in the complaint, we don't even know if it's true yet. Are those really their service providers? What did they really do? How did their RFP go? I don't know yet. We're going to have to see their responses. I mention that because I've heard from several employers about kind of reacting to the complaint. And I think it's really smart to take a look at it, take it seriously. I've heard several folks tell me they're going back and thinking about their committee structure. I loved hearing on the panel yesterday about, make sure you're documenting things, make sure you're, keeping good records. If you're doing a good job as a fiduciary, you want the record to show that. You want to show everything that you thought about. You want to show that maybe you didn't choose the low price, but there you had reasons for that, and you weren't obligated to do so. And here's how seriously you take being a fiduciary. That's really important. Same with making sure who has fiduciary responsibilities under the plan. If they've been delegated to somebody else, does that person know they're acting in a fiduciary capacity when they're making certain judgment calls? So some kind of just best practices on governance, I think, are good things to focus on. What makes me a little more nervous were some folks called me, that night saying, should I go through to a pass-through PBM? Do I need a specialty carve-out? I don't know yet, right? I could think of a ERISA fiduciary breach argument on kind of any plan arrangement that you might have. So I don't know that I'm seeing the need for a plan design change right now. I think this is just my opinion, but just pay attention to the lawsuit, focus on governance, and just monitor what's going on here. But I do think it's going to be a good one to pay attention to, and I think that we're going to see more. I don't know when Johnson & Johnson will be filing their response. When I was researching this recently, I think that's a little bit gray. The parties in a litigation oftentimes get together and they make an agreement on the calendar. Okay, I file this by this date, you have this long for this one. So sometime soon, I think we should be knowing what's going to be filed when. And if you have any responsibility internally for monitoring this, that'll be something good to get your hands on, because then when new stuff will be coming out. Okay. Mental health parity. So I thought it was great yesterday on several of the panels when folks were talking about 2024 priorities. I kept hearing, mental health continuing to be a priority, which is something I consistently hear from a lot of our employer members at the American Benefits Council. And I know that there's, different categories of what you all are working on, right? You're putting so much effort to make these wonderful benefits to help employees and their families, and yet you also must deal with mental health parity. And I know it's a thorn in your side, and it's, stressing everybody out. So I wanted to update you that I think you know, but just to level set, the mental health parity rules have been in effect for a long time now. I think we all kind of thought we knew what they meant. And then a few years ago, Congress passed a law that required plan sponsors to document in this comparative analysis their compliance with some of the requirements. And the agency started asking for those kind of compliance reports from employers. And they found 100% of the time that those compliance reports were not compliant. So they wouldn't really tell us what was supposed to go in that report, but they would tell us that 100% of the time we were not doing a good job. So that has been a frustrating journey to be on, and we've basically begged them for guidance. Please give us a sample report. Please give us regulations. Anything. Write it in the sky. I don't care. Right? Like, tell us what you want us to put in a mental health parity report, because employers care so much about this. And the consequence of having a non-compliant report and a final determination of non-compliance is that the employer is listed publicly in a report to Congress and has to send every employee a letter saying we don't comply with mental health parity. So nobody wants to do that, okay? I think we already were trying to comply with mental health parity before, but they've taken it up a notch. So this past summer, they put out really extensive regulations telling us a bit more about what needs to go in this report. So that's helpful. But they also made some substantive changes to the underlying mental health parity rules that on a high level could underline the ability of employers to impose medical management. And so that has caused some concern. And, we and many others filed really substantive, long comments trying to tell the agencies that we know these rules are well-intended. Employers are deeply committed to supporting their employees' mental health, but we need rules that we can comply with and that are clear. And so when I mentioned earlier their priorities, this is one of their priorities. I think this will get finalized this year, no matter how hard it is for them. They got around 10,000 comments on these proposed regulations. That is a lot of comments to read because these were really substantive. Sometimes the comments that the agencies receive are kind of cookie cutter form letters. So you say 9,000 of these just all were a one pager that said the same thing. But I think these are all fairly unique and bringing up different issues. And there are legitimate views on all sides of things, right? There's like the mental health provider community, and there are providers, themselves. There's consumer groups, there's employers, there's insurers, PBMs. Everybody is focused on these rules and how they're going to work. They've indicated to me that the rules aren't imminent, which is like government speak for any day now or even any week now, but later this year is what they told me. So I think that means they'll basically take as much time as they have or as much time as the White House gives them to finalize these. And when they come out, I think we're all going to need to take a close look, because I just basically wanted you to be aware that it's not just that they're going to tell us how to do these compliance reports better. I think they're going to change the actual substantive requirements themselves. That might in some cases require plan design changes. So something we're going to have to focus on when those come to final. I have heard, interestingly, that they've changed their enforcement approach recently a little bit on mental health parity. You all may have heard over the last 2 years, we heard they were going out to people and asking for this compliance report. And then sometimes they were writing back 100 or 200 questions to an employer, asking all kinds of things. I don't think they found that very effective. It's taking them forever to go through all the information they asked for. I mean, I don't know why they asked for it, but they asked for it. And I think now they're overwhelmed with what they've received back, and it's slow going. So I've heard they've pivoted to ask more surgical questions, more about a network adequacy. They're really, really focused on mental health provider networks. And so they're coming back in with a subpoena. I heard at this point, they're asking like 7 or 8 really targeted questions, and then they're going from there. I've heard this can be more scary if you're the employer, because you're usually hearing from the national office at the Department of Labor, and it's the subpoena, and it just feels a little bit more scary. But it feels more efficient than when you get 200 questions from the regional office that you don't even know what the questions mean. So that's I think that's an interesting development. I can't yet tell if I think it's good or bad, but I definitely know that getting hundreds of questions from the regional office that then you have to pay outside counsel to help you answer, that then sit with DOL for the next 2 years, did not seem like a good use of anybody's time or money. So hopefully this more targeted approach is at least efficient and effective. We'll have to see. I did also want to mention that DOL, the part of DOL, Department of Labor, that oversees mental health parity, and a lot of the other rules we're talking about today, is being kind of investigated by their inspector general at DOL to check into how they've been doing on their enforcement of mental health parity. I think there have been complaints, including some Congress members are aware of the frustration of employers. So no one really knows which way that report will go. So I think some folks are a little worried that DOL might utilize this experience to get more funding for more enforcement, which I don't think is what we want. It could also be an exercise that shows how inefficient enforcement has been and improve enforcement. So this is another example of like, you just have to wait to see how it plays out. A lot of these things could go like take a left turn or take a right turn, you never know. But the good news is that DOL is, I think, taking that investigation seriously, of course, and it sounds like trying to make some improvements to enforcement, which I know has been really frustrating for employers over the last few years. Another issue that came up yesterday, I know we talked a bit about patient assistance in the pharmacy space, and I know many of you probably know more about that than me, but I wanted you to know about one particular issue that's going on that's a hybrid of regulatory and litigation, because it could potentially hamper in some way the choices and the flexibility that plan sponsors have. You are sure well aware that over the last few years, there have been different views on kind of copay accumulators and drug coupons. Are they wonderful for the patient? Are they harmful in the cost arena? Should they have to be counted towards deductibles and out-of-pocket maximums? Should they never be counted? Should they always be counted? People have different opinions. It's changed over time. There was a bit of a blip a few years ago where the Department of Health and Human Services put out a regulation that I think implied to many of us that there were some circumstances in which a copay accumulator was not permissible. So basically, they put out a rule saying sometimes you have to count the value of the coupon towards out-of-pocket maximum in the plan. Sometimes you don't. It was more confusing than that, but I'm just trying to boil it down for you guys, because then the advocates came in and said, whoa, our copay accumulators are really important to us. They save us millions of dollars, and we're really worried about the cost impacts and kind of the incentives that are set up with requiring us to always count these coupons towards the out-of-pocket maximum and deductibles. So the agencies clarified that they had not meant to say that. And actually, they meant that it is fine to do either. You can count the coupons toward the out-of-pocket maximums, or you don't have to count the coupons towards the out-of-pocket maximums. So that's where things stand now, which is why maybe you haven't heard about this issue as much recently, because we've been in a good place, right? It's up to you. But some consumer groups sued the agencies saying that that's illegal. Their interpretation is not consistent with the Affordable Care Act. They think, as you might imagine, that coupons should always be counted toward the out-of-pocket maximum and should always be counted towards the deductible. And so just a few months ago, the district court judge in that case ruled and said, kind of agreed with the plaintiffs on that one, but essentially what he said was, I agree that the agencies can't say that kind of the same words mean two things. It can't be the case that under the Affordable Care Act, cost sharing includes coupons, and also cost sharing does not include coupons. Like, it's one or the other. It can't be both. That's not good, like, legal interpretation, basically. So he sent it back to the agencies to say, pick one, kind of is what he said in a judge language. And so now it's back with the agencies to come up with guidance that I think they might be trying to make everybody happy, and that worries me to some degree. You guys are probably aware of the side issue for high deductible health plans, which is that we believe under current guidance, if a plan counts the value of coupons towards a deductible or out-of-pocket maximum, they're no longer a high deductible health plan. So there's the side issue of, will their guidance destroy all high deductible health plans? I do not believe so. I know they're aware of that issue. They're going to have to thread all these needles. So if they say that we always have to count coupons towards the out-of-pocket maximum, I think they're going to have to put out guidance, again, clarifying that that doesn't undermine high deductible health plans. They have various other options that they might have in front of them. We've continued to advocate on this and the importance of the ability for employers to be able to have the flexibility to choose not to count the value of coupons. But there's a lot of push from the consumer side. Bipartisan group of senators many wrote to the agencies saying that they believe coupons should count. And one piece of not good news is that at first the government appealed their loss in the district court to the higher court. That's usually signals that they don't agree with the district court ruling. they indicated they planned to file an appeal, and then they withdrew that. So they said, never mind, we're not going to appeal this ruling. I don't think that means that necessarily everyone's going to have to count coupons all the time, but it's not a good sign. I heard them try to make that neutral in a recent conversation with someone from HHS. He said, oh, all the time we decline to appeal, but that's not my experience. They don't always decline to appeal, and they certainly usually don't say we're going to appeal and then never mind, we're not going to appeal. And in the middle of that time period, you got a letter from 50 Congress people. So they are facing pressure, I think, on this one. So we're working as hard as we can to try to defend the ability of employers to have accumulators. But I want you guys to know there's, I think, a lot of political and optics pressure going in the other direction. So that's really active and something to note. In the interest of time, I'm not going to get too deep into something going on with copay maximizers, but I did want to mention that there's an annual notice that HHS puts out. It's like 700 pages, and it's an awful one to read because it's always like one half of one page has something really important on it. So you got to hunt for it. So that little Easter egg this year was some discussion that could impact the ability of plans to offer copay maximizers. Basically, right now, as I understand, plans are able to kind of increase the cost sharing limits on certain drugs is because they're designated as not essential health benefits. And so that can support different plan designs. The agencies essentially said, what do you all think if we said, if you cover a drug, it's always an essential health benefit? So we submitted a comment saying, please clarify that you meant only for this to apply in the individual and small group market, which is how they discussed it. I didn't want to concede that it's a good idea in the individual and small group market, but we're focused on large group and self-insured. And I've had some informal conversation with them saying like not everybody was looped in and they're thinking about that. But I did want you to know that there is something afoot with a redefinition of essential health benefits, which sometimes happens. And I know it sounds pretty arcane, but it's really important because as we all know, what counts as an essential health benefit is what, that means you can't apply an annual limit, you can't apply a lifetime limit, and you have to count that drug towards the out-of-pocket maximum. So it's actually really important. There are oftentimes process fouls within the agencies on some of these definitions that reside in one agency, but have really important implications for other agencies' jurisdictions. So this would be an example where the definition of EHB, essential health benefit, resides with HHS, but a lot of other agencies have jurisdiction over group health plans. So I think they're all getting clued in and saying, wait a minute, what was this rule and how would it impact our plans? Okay, briefly on preventive services, I just wanted to mention there's various things percolating here that you're going to want to pay attention to. You all know that the Affordable Care Act required health plans to cover preventive services without cost sharing. One thing that's potentially afoot is the agencies or the White House, I think, has indicated that it's considering whether it should require plans to cover over-the-counter preventive services, even if there's no prescription, so no involvement of a provider. I think they're primarily trying to get plans to cover new over-the-counter contraceptives without cost sharing. So you guys might have seen yesterday that they announced that the O-pill cost would be, I think, $19.99 a month or $49.99 for a 3-month supply. There are some, I think, in the White House who want to find a way to force health plans to cover that for free. Many employers I've talked to are worried about the ability to do this over the counter, as we've all just been through the over the counter COVID test experience, et cetera. And we know that there are a lot of issues there, but that one's percolating out there. They haven't proposed anything yet. So I'm worried about their timing. I kind of worry they're just going to throw it out there and not propose it so we can react to it. So keep that on your radar. I think that the reason I think they might do something here is this falls in their category of like women's health, reproductive rights, trying to do anything they can. And this is something that I think you could talk about politically and a pretty good talking point. So I think they might try to do it, but I think there are some legal issues. The other item I wanted to mention on preventive services is just litigation that I'm sure you guys have all talked about maybe a year or so ago, but I wanted you to know where things stand. Essentially, under the ACA, when a plan has to cover preventive services, that actually is 4 different categories of preventive services. Some are women's services, children's services, vaccines, and this other kind of catch-all. So that's the items and services recommended by the U.S. Preventive Services Task Force. So this is like colonoscopies, mammograms, PrEP, some other pharmaceuticals. Some folks, an employer and some individuals sued saying that that requirement is illegal, in particular with a focus on PrEP and some other things like that, and said it violates the Constitution that the ACA and the agencies are making health plans cover these items and services without cost sharing. And those plaintiffs essentially won in the lower court, and now it's on appeal. So the rule is stayed right now or paused, meaning if there's no current impact, but yesterday or Monday there was a discussion in the court. So that's still out there. I wanted to mention that to you in particular because I thought the reporting was particularly confusing when the district court ruled, which is to say, even if employers are not required to cover preventive services without cost sharing, that doesn't mean they're prohibited from covering preventive services without cost sharing. That just means that plan sponsors would have the ability for one subset of preventive services to think about, do we still want to cover it? If we want to cover it, do we want to cover it with or without cost sharing? So I want everybody to know that because some of the headlines were like, employers will no longer cover mammograms, right? Like that's not a good headline. So I try to talk to reporters and make sure they understand what's going on here. And I know many employers and many of you were covering all of these things way before the ACA because it makes sense from a cost and employee health standpoint. But that one can get, the optics of this one can get kind of squirrely. I know we're almost time for Q&A, so I'll just mention that you guys have your breakout on transparency requirements. I'm sure Madison's going to do a great job telling you everything there. So I did want to mention the one thing we're watching for is transparency requirements related to prescription drugs in a public file. There was a public file that plans were going to have to put out on the public internet that showed different information about the prescription drugs covered under their plan, but they were sued by PCMA and some others. And so the agencies paused that guidance and said, okay, we're going to take a pause on that guidance. But then they were sued by somebody who said, you didn't have the authority to pause that. So then they said, okay, we're going to unpause that and we're going to require this again. And so where that stands is they owe us all guidance on what they want in this prescription drug machine readable file. And they have assured me that we will have substantial time to come into compliance. But on the transparency front, I just wanted you to know that's still percolating and we haven't yet seen the guidance. And I'm just not quite sure how long we're going to have. I'm worried when they think they've given us substantial time, and it's not really what I would think is substantial time. Okay, I'm going to skip surprise billing. If you want to hear about it, happy to talk to you. A lot is still going on there, in particular with all the lawsuits that are happening. It's something we track really closely. And then just lastly here, I have a little list of other issues that I hear about routinely. One I wanted to make sure is on your radar because you might see it more in the news soon. There are non-discrimination rules under the Affordable Care Act related to kind of healthcare providers, including in some cases issuers and TPAs, requiring them not to discriminate on various issues, including in some cases gender identity, sex, religion, etc. Those rules and their scope have ping-ponged back and forth since the ACA passed based on the who's in charge at the time. And so my expectation is the new final rules will be broader than they were in the prior administration. That could impact, for example, something like coverage of gender-affirming care. So that's something to watch. I mention it to you because it's at the White House now under review. That means it's almost ready to come out. That's like the last little part of the car wash before it spits out to us. So once we see it on the White House website, that means it's coming soon. So if this is something you've had to grapple with before, wanted you to know it's coming back. I'm sure you guys have heard from employees about IVF and the Alabama Supreme Court ruling. That's something else I'm happy to talk to anybody about. It sounds like Alabama might actually kind of resolve the issue, but I still think it's out there. And I heard that, for example, who's sitting next to Jill Biden at the State of the Union is going to be like the first person who was born under IVF. So this is, we're going to be talking a lot about IVF this year. So be ready. Last is just to the extent you're interested in fixed indemnity insurance, there were some major rules last summer proposed that would really limit the ability of employers to offer this largely voluntary benefit. And they received a lot of comments. And I think that's something else that we'll be hearing about again soon. Like I said, I did not have my email address up here, but I would love to hear from you if you wanted to talk about any of this. And I'm happy to take questions. And I will add my email address to the PowerPoint. Any questions?
Hi, thank you. Two questions. You hit on both of them. The first one, there's been several states in the last couple of years that have passed laws related to steering mail order prescription drugs. I believe it started in Oklahoma and then Florida most recently. CVS has taken the position that ERISA preemption doesn't apply in these situations. And I've never heard a good reason, a layman's reason, as to why ERISA doesn't apply in those situations. And then two, regarding the DC ruling on copay
Yeah.
assistance, is it your opinion that employers don't need to modify their plans today to comply with that ruling? Or is that binding and employers need to consider changing in the near future?
So I'll take your second question first. Thank you. Those are both great questions, right? I don't think you need to change anything. The federal agencies actually went back to the judge and said, here's how we understand your opinion. We think you told us to do more guidance on copay accumulators, so we don't plan to do enforcement any different than we were, which is to say no enforcement, right? Because they were basically saying everything's fine. And the judge said, yeah, that's fine. I didn't say what the answer had to be. I said you had to do guidance. So I know some people have said that, and I've confirmed, like, that there's no current change in the law. There's just something to monitor. So no, I don't think you need to change plan design right now. On ERISA preemption, yeah, my opinion is that the law in Oklahoma after the 10th Circuit, so that's the relevant appeals court, once they heard that case, thank goodness, we got some good news on ERISA preemption, and they found that that law was preempted by ERISA. So I think that that law is preempted by ERISA. This is the Mulready case. I'm sure you guys have all heard about it. The plaintiffs in that case went and asked the full court, the full appeals court, to rehear the case, and that full court declined. And so now, as we understand, they're going to pursue Supreme Court review. So that could always change in the future. But I agree with you as an ERISA lawyer, the Florida law, the Oklahoma law, I just think they're clearly preempted. I thought they were before. But you raise an important point, which is like, it doesn't really matter what I think, right? It matters like what a court thinks and what your service provider is willing to do, because in some cases, if they feel like their license is, on the line or whatever. So it's like one interesting thing is to know what your lawyer thinks, but unfortunately, that's not really the practical answer. The practical answer is, what will your service provider do? And has there yet been litigation? So like in Florida, I've heard rumors, I've heard talk of like who would be the best plaintiff. Ideally we find a local Florida employer to bring suit, but that hasn't happened yet. I've also heard confusion. We don't all really know what the Florida, like even on its face, does the Florida rule apply? And everyone's scared to ask Florida to clarify, because sometimes it's better to keep it gray. So I agree with you, but I also understand that doesn't really, help you a lot. But yes, I agree with you that it's preempted, but I think employers are in a tough spot.